C. I will be the host for this entire next 1.5 hours. October is the Breast Cancer Awareness Month, and between myself and Dr. Wee, we would like to share a Saturday afternoon with you to help us all understand female cancers a little bit better. We have the next slide, please. Yeah, so basically, today's program is very simple, but it's always very important to get the simple things in tight. So for example, like Dr. Wee is going to share with us that lump in my breast, is it serious? Followed by myself, I'm going to share a little bit more information. Perhaps you've heard it, perhaps you have not, about chemotherapy, some toxicities about chemotherapy, what is necessary in chemotherapy. Do all cancer patients with breast cancer require chemotherapy? Followed by some time for Q&A. I do welcome some Q&A while the talk is going on, but as there are apparently 700 people who have signed up, and right now we are seeing 200 over participants who have signed in, the questions are coming in fast and furious. I do apologize if some of the questions seem to have been ignored. It by no means is because we don't feel that that question is important, but by sheer number of questions that are coming in, we may not be able to answer every single one of them. But many of the questions so far has been pertaining to the talk that is going to come up. So I would suggest that perhaps you can keep some of the questions till after the segment is over. Next slide, please. Yeah. So first of all, I'd like to start off by introducing Dr. Wee. Dr. Wee is a very good friend of mine. Basically, he's a very renowned breast surgeon. And prior to him coming out to private practice to focus on patient care, he was the chief of breast surgery in the year 2000 at National Cancer Center in Singapore. He is a very, very caring surgeon. We tend to see many patients with breast lumps, but not all breast lumps are cancerous. So without further ado, I can hand the podium over to Dr. Wee, who will share with us what are the important facts about lumps and bumps. Thank you very much. And just one more thing about housekeeping is that at the end of this webinar, you will be directed to a feedback. I would really do encourage you to help us feedback the session so that we can make the session a little bit more interactive and better for you the next time. Thank you very much in advance. And now over to you, Shubha.
Thank you, Witi. Let me just try to get the slides open. Can everybody see the slides? Hello and good afternoon to everybody. Thank you very much for taking time this afternoon to join us in this session. I will first start off by thanking Dr. C for the kind introduction and all of you for joining in. Now, this afternoon's talk, I intend to cover an issue on breast cancer, and the topic I will cover with some of the padding with some of the facts that's come along is that lump in my breast, is it serious? And so far, I've seen some questions come in, and I hope that some of the questions that have not been answered will be covered in the talk to come. Now, why do we really get women worried about the lump in the breast? The key issue at the end of the day is a question of whether is it breast cancer. And that really preoccupies the concern of a lot of women when they feel a lump in the breast. And in Singapore, rightly so. Now, even if you look at the world in general, this is an article in 2016, roughly about 4 years ago, when the World Authority came up to predict that by the year 2030, cancer could be the dominant killer among women. And of course, this was pre-COVID, but the significant thing in this article in the Straits Times was that they actually by then said that breast cancer was set to double from 2016 right up to 2030, and we are about only 10 years away from that. So breast cancer indeed, all over the world, is a cancer that's increasing in incidence and affecting more and more women as the years to come. And that's a good thing that you are joining this session to try to learn a bit more. Now, specifically in Singapore, what are our data like? Now, it is clearly the number one cancer among women. And at the moment, based on our data, roughly about every 1 out of 3 or 4 cancers in women arise from the breast. And with the rest of them, all our cancer studies say that the rest of them are actually quite far behind. And this incident, unfortunately, is increasing. This is older data, but I think we're coming closer to about almost 2,000 cases, new cases of breast cancer a year in Singapore. And the alarming concern is that the number of new breast cancers every year seem to be increasing steadily. And that is a real concern. And if you look at our own data to try to understand better, it is a cancer that seems to affect women in the later years of their life. And in general, the risk for breast cancer does increase as the woman gets older. And our statistic in this profile basically reflects the fact of a baby boom effect, which means that there are more women getting older, more women living longer, and therefore we're going to more likely to see more cancers occurring in the older population as well. Now, the most common cancer among our collection of data, the most common presentation of cancer of the breast is a lump, and that's why a breast lump is of concern. In Singapore, at diagnosis, on average, the cancer size is about 2.5 centimeters in size. 2.5 centimeters by an inch at diagnosis will make it a stage 2 breast cancer at diagnosis. And certainly in this picture on the right side, if you can see a bump above the nipple here, by now that bump is easily about 4 to 5 centimeters in size, almost encroaching towards a late stage 2 to stage 3. So we are still grappling with large cancers or bigger cancers at diagnosis. And that is something we aim to actually cut down drastically, because essentially the size of the cancer affects the survival from the cancer. In general, cancer cells will remain in breast as a lump for some time before it starts to spread. And therefore, the size of the cancer within the breast matters. This statement is not always, because sometimes cancers can spread depending on the nature of the cancer of the breast. They can actually spread early, even in its growth. Now, death from cancer, the morbid bit, death actually comes from spread of the cancer to other parts of the organ. In other words, if the breast cancer stays within the breast and doesn't spread anywhere else, it is very unlikely to threaten life. If most, we just remove the breast and then everything goes back to okay. But in terms of breast cancer, it is a spread of disease elsewhere to other parts of the body that actually finally causes the patient to succumb. So a good take-home message would be that the smaller the cancer at detection, the better the chance of survival for a woman if she has breast cancer. So very often the question, the consultation that I have brings forward a patient with a lump, and the question that she always asks would be, is my lump cancer? Now, in general, lumps in the breast are very common among women. Most of the time, the breast is a very active organ. Almost all the time, it's an active organ. And every month it responds to the normal hormones. It reacts, proliferates, and then after that, once the menses come, it settles down again. So in this process itself, sometimes lumps are formed. And in general, if you're talking about breast lumps, even actual breast lumps, seldom are they related to cancer. Most of them are not cancerous or benign, estimated to be more than 80%. Most often, lumps that women present that are detected are actually not really lumps, but just some areas where the breast feels a bit uneven, a bit lumpy. And that is sometimes enough concern for a woman. Now, this kind of lumpiness is often commonly mistaken for a lump. Are there any particular reasons? Well, the lumpiness basically largely is a variant of normal. It means that when a woman touches her breast, she feels that there's a bit of unevenness, and that belongs to the capsule of the breast, causing a little bumpy feeling. Generally, it is more common, like I mentioned earlier, premenstrually, in younger women where the breasts are more active, and also in particular situations like pregnancy and breastfeeding, where the breast can be particularly lumpy, largely because of the preparation of the breast to support pregnancy and lactation. In this kind of setting, which is of a benign situation, the sensation of the lump is largely more of a patch where the lump seems to continue running around. It's a patch rather than a particular area of hardness. So that is the unique clue that most women can have if you want to try to do your breast self-examination to determine whether it is a particular lump or not. Now, regards to the types of lumps that women encounter, as I mentioned, most of the lumps tend to be benign. This is a list that's not comprehensive, but it covers the most common causes of lumps in the breast, which include things like fibrocystic change, which some women may have heard of. Infections can cause lumps to appear. Cysts are very common. They can sometimes be felt and present itself as a lump. Fibroadenomas here are largely benign, non-cancerous lumps of the breast, which are common, especially in young women. Papillomas are active growths, usually related to the nipple, presenting with a bit of discharge. By and large, still not cancer. And of course, among the whole list here, the one that raises the greatest concern is a cancer. Now, cancer as a lump, presenting as a lump, known as a lump, as I mentioned earlier, is the most common way cancer is found in a woman's breast today. So the lump is the most common symptom that we encounter. In general, if a lump is cancerous, they tend to be silent in the early phase. The lump is a definite lump. We call it discrete. You can feel it as a specific lump, like a little peanut under the skin. That's one way to try to understand, or maybe like a little chestnut. And often the lump, by way of feature, is painless. And that is sometimes where it gets troublesome in terms of encouraging women to come forward for treatment. Because oftentimes it is an innocent lump. It sits there quietly, doesn't disturb the lady at all. She can feel it. She goes about a normal activity without being troubled by it. And generally, she would be surprised when we tell her it's a lump. That the lump is a cancer, because she would say that I've been well. How can this be a cancer? I don't feel ill. I'm actually doing everything I'm doing. I don't feel too inconvenienced. But essentially, a painless lump is actually one of the most common features of a breast cancer. And pain in general is very uncommon. Yes, there will always be women with pain that rising from a breast cancer. Oftentimes, when there is pain associated with a lump that's related to a cancer, the cancer tends to be a bit more severe. It's a bigger lump, there's a bit of swelling around it, and that is the thing that brings in the pain. And the other thing that people are mistaken about sometimes about lumps in the breast that can be a cancer is the mistaken belief that if it's a cancer, the lump is not mobile, the lump is stuck. Because the common thinking is that it has roots, it doesn't move so much, and therefore if it's mobile, the reverse says that it is not likely to be a cancer. But when cancers are small, they tend not to be stuck, they tend to be mobile. And as they grow, only then do the features of immobility come in. So sometimes the fact that it's a mobile lump does not really rule out the possibility of a cancer. In general, look out for early features, other features that can sometimes come with a cancer as a lump. Now, there are other features of cancers that are less common, but I will show you some examples of what other features that come with it. Sometimes there can be changes to the nipple. What the common thing that people are concerned about that raises concern of cancer would be a discharge from the nipple. Now, nipple discharges are common. The concern of cancer comes with discharge that tends to be either blood-stained or tea-colored or dark-colored, and usually on one side. So these are the clues of a discharge from the nipple that would be of concern. Common discharges like milk-colored discharge, milky-colored discharge, clear-colored discharge, generally speaking, are not of that much concern relating to cancer. And often a cancer which presents with a discharge should be a cancer that's actually quite central in the breast, probably just under the nipple. Other changes that may occur include a rash or color change. And as you can see in this case, the tip of the nipple looks very angry, reddish. By no means can I stare at this and straight away say it's a cancer. Sometimes common rashes do occur, but certainly when you encounter a change like that, it is something that has to be looked into to make sure that we are not overlooking a cancer. The other thing, of course, if you leave the rash alone and the rash eventually eats up the nipple, this is one of those situations where the nipple is actually destroyed by the cancer. One of the not so common cancers, types of presentations called Paget's disease would look something like that. And here it's actually quite straightforward. Other features that come with cancer could be a dimpling in the skin, a new dimple. The skin just gets pulled in. Usually that means that there's a lump, that's a cancer that's underneath, dragging the skin and getting stuck to the skin. As it changes, as you leave it alone, the dimpling essentially will allow the cancer to grow and the skin overlying will start to change. And then you get this ruddy red color overlying the tumor, the cancer itself. And by now, there's probably a fair-sized cancer under the skin. The other feature that sometimes may herald a very advanced form of cancer would be what we call an orange peel appearance to the skin. And by the time you see this orange peel appearance on the breast, especially it's one-sided, it denotes that there's actually quite a fairly large tumor that's actually trying to pull the skin in different areas, and you see all the pore marks being accentuated in this process. So other features of cancer may sometimes be present in addition to a lump, and these are additional clues that can be looked out for. Though by the time we see this, generally speaking, we not so happy because we're not likely to be dealing with something that is that early. So we go on to the next point about how do people discover lumps in the breast if it's not self-discovered? How do I know that I have a lump? This is closely linked to the 3 pillars of breast cancer screening, which relates to, from the left side of the screen, breast self-examination, and then moving to the top of the screen, there's clinical breast self-examination, and finally, the commonly mentioned mammography. Now, taking each in turn, now breast self-examination is something that I feel that women should be familiar with. Examining their own breasts, understanding the texture of their own breast, the feel of their own breast. Every woman's breast feels a bit differently. Every woman's breast feels a bit differently at a different time in the month and a different time in their life. So doing regular breast examination is something they themselves can arm themselves with so as not be caught off with a sudden appearance of a lump. Now, monthly checks can be done in the comfort of home, so actually, and it's almost no cost. The time to do it is usually the best done while you're showering, then you examine to feel whether there's any hardness or any change that wasn't there earlier from an earlier examination. It is something that can be easily learned. I mean, there are enough YouTube videos teaching people how to do breast self-examination, but generally it is an art that is actually quite difficult to master, especially for women who are troubled or has all along been having lumpy breasts. In general, when women are taught to examine breast lumps, the lumps they detect tend to be, in general, about the size of about 2 cm in size, 2 centimeters in size. Smaller lumps are harder to detect, but it is still better to do this self-examination to catch a lump early rather than wait for it to be much bigger before it's detected. How well it can be done, how well a lump can be discovered, there are many factors that affect it, and the fact that it's not so foolproof should not distract from the fact that women should still try. Now, how easy is a lump to be discovered depends on many factors, or not really within anybody's control. It depends on the size of the lump, how hard the lump is. Obviously, the bigger the lump, the easier to feel. The harder the lump arising compared to the surrounding area, the easier it is for the woman to detect the lump. How deep the breast within the breast is important because a lump that's nearer the skin is, of course, easier to feel and smaller compared to one that's deeper. The location of the breast is the other factor because lumps in the edge, around the edge of the breast, away from the nipple, generally can be picked up as smaller sizes. Lumps smack in the middle of the breast where the largest volume of the breast is tend to escape detection early. But these are things that are all not within anybody's control. Background natural lumpiness does get in the way. A woman who's had lumpiness all along sometimes will find it harder to pick up a new lump. And the other clue that sometimes is useful to look out for is other associated symptoms, which I tried to show earlier in the earlier slides. The last thing is sometimes how complete, because the axilla, the armpit area, is where sometimes lumps are missed, because women think that the breast will end just below the armpit level, but the armpit itself sometimes can hide lumps or lymph nodes that may be of significance. The next way of detecting breast lump depends on the doctor or trainers, and this generally can be considered part of a routine checkup. When you see your GP, you can always ask him to just do a breast examination for you. And usually the factors that the GP may be aware of details of whether you have any concerns about the breast and even your family history, whether there are any related relatives with breast cancer. And with trained expertise, we can bring down the size of average size of a detected lump. And generally, we will say the doctor or the nurse who's trained can pick up a lump that's smaller, probably about 1.5 centimeters in size. And finally, is this whole issue about early detection of breast cancer related to mammography. And mammography is a very important way for us, and it's a very well proven way to detect cancers early. And in this whole aspect of mammography, often when you remember, this is the key emphasis of the annual Breast Cancer Awareness Month, and this is a lovely poster from the Breast Cancer Foundation about making women aware that they should be aware of changes in their breast. But whenever we mention mammography, this is in reality what it means. You almost get this impression, because it's a very uncomfortable examination, the woman really gets this impression that she has to be dragged to a mammogram, saying, do I really need a mammogram? But really, it is not that bad if you try to understand the objective of having a regular mammogram. The mammogram can detect lumps that are much smaller, very, very much smaller, very, very breast cancer in the very early phase, and it's very well established that this way of screening for breast cancer can significantly reduce the likelihood of death from breast cancer. You may show signs on the mammogram that indicate the presence of cancer, like a shadow of a lump in general, or even little calcifications called microcalcifications. So these are clues that we look for that may suggest a cancer. And in the middle of this hook wire, you see this irregular looking thing, and that itself is a cancer. Very early phase cancers can be picked up. And if you look at it, these little bits of calcifications right in the middle here denote early cancer change. And this kind of cancer, if it's picked up on the mammogram, there's about 90% chance we are dealing with stage 0 cancer. So very worth picking up, because if you catch a stage 0 breast cancer, it means the cancer is so early that there's no likelihood of it spreading. And if you remove this cancer, the likelihood of further treatment like chemotherapy is almost never necessary. And if you, of course, if the calcifications are left alone or picked up later, sometimes you can see a bit squiggle lines. There are squiggly lines near the tumor. That actually means that the calcifications are starting to develop a mass, a growth. And if you leave it long enough, certainly then it becomes an ugly star-shaped lump. And this, by looking at it straight away, we will conclude that it's a cancer. Now, the accuracy of a mammogram is always the issue that patients question whenever I discuss the subject. And it comes down to how accurate is the mammogram in catching cancers. Now, the accuracy of the mammogram in catching a cancer depends on many factors. And one of the key factors is the first point is the density of the background breast tissue, which means how dense the breast is. For women who have gone for mammograms before, you understand that this becomes a consideration. And density of the breast, which means how white the breast is on mammography, is age related. And that hopefully covers one of the questions that I saw earlier. And why are mammograms not done in young women? Mammograms can be done in young women, but the ability to catch a cancer early in young women is affected by the fact that young women tend to have dense breasts. So smaller cancers are sometimes harder to pick up. In other words, in younger women, the use of a mammogram in early cancer pickup is inferior to using it in older women. It is not that it cannot be done, but the accuracy rate, reliability rate of picking up an early cancer is lower. There is also this other thing about called disruption of the background tissue by the lump. As you can see earlier, there was how obvious a cancer appears on the mammogram depends on how the background tissue is, how it disturbs the background so that it shows up. I will show this and try to demonstrate this in a later slide as to how come that also affects our accuracy in mammography. And the accuracy is also affected by the amount of compression or movement of the patient during the mammogram, because that's very important. And clearly, this is the aspect of the mammogram that most women are very unhappy about. But for that period of cooperation during compression, if it allows us a very accurate picture, it actually will go a long way in the accuracy of the test. But in general, as a common rule, we will know that about 8 to 10% of cancers are not detected by mammography. So mammographies are never 100% accurate, but it is by far one of the better tools we have if you are trying to find an early breast cancer. And this, of course, as I mentioned earlier, especially so in younger women where the breast is less dense. Let me try to illustrate to you as simply as I can an image of a set of mammograms in relation to a cancer. If you look at this set of mammogram labeled R and L, right and left breast, this set of mammogram belongs to the same lady. Okay, so the breast straight away, you can see even on mammography, the right and left breast may sometimes be very different. Is there a cancer in the breast? In this set of mammograms, the answer is yes. The cancer is here in the right side. This is the cancer. There's no cancer on the other side. So this one stands out because you can see that there's a cancer there. Now, if I were to take this cancer out, which whatever I can, all right, remove it from this image, and then transpose it to the other side on the left side. That means the same cancer shadow is now transposed onto the other side. If you didn't see me click fast enough, you will have difficulty trying to pick up this same image just transposed on the left side. And here is where the same image has been transposed to the other side of the breast. And this, of course, represents a cancer on this side. And if you transpose this lump just by looking now, if you don't look carefully, no one will pick up this cancer because it's mixed in the background. And this is the illustration of density. Density is the whiteness of the breast on mammography. Cancers on the breast tend to be white or light gray. So if it happens to be, the cancer happens to be an area where it's naturally dense, cancers can be missed. And that is the reason why there is always still, the mammograms basically are not 100% perfect. Some cancers can be missed if it's an early lump. Are there early clues that we use to try to pick up other tests that we can conduct to catch breast lumps early? Yes, I think some of you may have encountered there are additional tests that we can use. We also use other radiology tests like ultrasound scans of the breast to look for lumps, as well as sometimes we add on MRIs. Now, breast ultrasounds are exceedingly useful for early breast cancer detection in the presence of an early cancer presenting as a lump. You can sometimes detect lumps as small as 2 to 3 millimeters in size. So very small lumps can sometimes be picked up by a good ultrasound scan. And often they are used in conjunction with mammography. Generally speaking, ultrasound examinations are a lot more comfortable. There's no compression, no radiation. Women find it a lot more comfortable. And it's particularly useful from my view in patients who have dense breasts to be added on, to have an add-on that ultrasound scan following their mammogram, women with dense breasts. In young women, where we acknowledge that mammograms are not so reliable, we use the ultrasound scan, and sometimes for symptom evaluation. In other words, the patient has some soreness or some lumpiness she's not sure of, and the mammogram doesn't show anything. We can sometimes use the ultrasound to give us certain features that may help us clear up the fact that there may be nothing serious going on. And of course, when the findings are inconclusive on mammogram or clinical, the ultrasound scan does add additional information for us to make an opinion. So essentially, how does anybody know if the lump is a cancer? Now, breast lumps can be evaluated in many ways. The doctor will does a clinical evaluation. She will take note of what the lump is like to the lady, how long it's been there, what is other symptoms that they have. The patient age is always taken into consideration, as well as if she has a family history of cancer. Other ladies in the family with cancers maybe will increase the risk of her chance of having cancers. And the doctor will also evaluate the lump that is presented to feel whether the lump feels like a cancer, because those are features that sometimes doctors are trained to pick up. Results of mammogram, ultrasound scans are also taken into consideration to decide whether it is likely to be a cancer or not. And after this whole process, often in my clinic, what I generally come down to is, can the lump, or is it real? And if the lump is real, can the lump be left alone? So this is the thought process that most of us doctors will have, or breast surgeons will have. When you have a lump, the whole process is, can it be left alone and not have unnecessary tests done? In other words, are we sure after this whole process that it is safe, that the lady does not have a cancer? Now, oftentimes, if there's some uncertainty or anxiety, the biopsy tests are conducted. Now, biopsy, by and large, is still important if we want to establish a clear diagnosis. Tissue biopsy refers to the removal of tissue for analysis, and the amount of the tissue removed from the lump for testing will affect the accuracy rate. And that is also therefore determined by the biopsy method. Biopsy methods can come from taking various amounts of tissue from the lump, and it can vary from as little as using a needle or the entire removal of the lump, which means that sometimes when we remove the entire lump, it is still called a biopsy. It is by far the most accurate way of finding out the true nature of any breast lump that is detected, either by imaging or by clinical. Now, biopsies for breast lump, in general today, with modern technology, any detected lump in the breast can be biopsied, no matter how tiny. As long as it can be seen, there is a way we can actually get tissue to go and test it. But for very small lumps, sometimes the biopsy itself may mean the entire removal of the lump, which is not a bad thing, because if you have a lump that's small, remove the entire lump means that we have tested the entire lump. It also means that there's no more lump in the breast, and therefore that brings with it a lot of relief. The answer is that there is no cancer. Now, today, removal of small lumps can easily be done, or even medium-sized lumps can be removed easily with keyhole surgery under local anesthesia. So we're no longer talking about lump removal these days with a big procedure involved. The method of removal or biopsy test, generally speaking, is best to be decided by the specialist after he's discussed with the lady what the overall situation is likely to be. So by way of concluding, I would just summarize that actually breast lumps are very common throughout life, and most lumps encountered in women during their lifetime are harmless. Cancer most commonly presents as a lump, and the easiest way to detect cancerous lumps requires women to some extent to be confident with breast self-examination, constantly aware of changes in their breasts. And when it comes to the serious bit of evaluation of any detected lump, it always depends on the doctor's experience and oftentimes involve some form of radiology test and sometimes even a biopsy. And not all breast lumps need to be removed, because by all the methods done earlier, if we can demonstrate that it is a safe lump, then sometimes it can be left alone. Essentially, it is important to let your specialist decide, after discussion with you, which is the best way to investigate the lump and how to deal with it. So as a summary statement, do not be afraid of any lump that you detect in your breast. Most times, as I mentioned earlier, it is nothing. See your doctor early to find out what it is. And as a cruel reminder of how life used to be, thank you very much. Dr. C.
Thank you very much, Shubok. For the next 15 minutes, 20 minutes, I'm going to share a little bit more about making decisions on treatment, especially to do with chemotherapy. The original title of this was Chemotherapy to All Patients Need It, but I thought it would be better to title this as Making Sense of the Treatment and Its Toxicities. So I hope that my segment will be a little bit more different from the usual breast cancer talk. Most of the time when we give webinars or we give talks, people want to know what's the greatest advances in breast cancer treatment, what's the latest chemotherapy. Well, to be honest, if we always have to talk about the latest in chemotherapy, it can change every year. And in fact, one 15-minute didactic speech by a doctor is never enough to cover, because it is getting more and more complex and it's getting more and more tailored. It requires a lot of understanding on the science of breast cancer. So it's not so simple to answer the question. Just now, someone was asking, what is the latest in breast cancer treatment? Well, I'm going to share a little bit here about how we classify breast cancer so that our audience here can understand what is important and who needs chemotherapy. So Dr. Wee has shared just now that mammogram and ultrasounds as an adjunct, not as a replacement, diagnostic scan can be used to detect breast cancer. But important things must be said again. Mammograms are very, very good in picking up microcalcifications in ladies who are older than 40 years old, because in younger ladies, the breast is too dense for the microcalcification to show up clearly. So when we have a so-called normal mammogram in a younger lady, it is potentially incorrect, purely because we can't see very much on a very dense breast. Just to put it very simply, it's like wearing a white dress on a white background. You can't see anything. You can't even tell what's the pattern on the dress because the background is so white. So that's a very simple way of looking at it. So breast cancer screening, we do advocate ladies to start from as early as 15 to 16 with a breast self-examination and a mammogram in an asymptomatic lady, meaning ladies with no breast lumps, no pain, no itch in the nipple, once a year from 40 years old onwards to 60, and then maybe once every 2 years, depending on their risks. For ladies with very high risk, genetic mutation carriers, sometimes we recommend breast MRIs when they're very young. But it is a very sensitive test. So the more sensitive a test is, the more background noise we pick up. So there will be a lot of lumps and bumps which may not turn out to be cancer, and it can be associated with a great deal of anxiety in ladies who have got very, very low risk of breast cancer to go for yearly MRI scans. Ultrasounds are harmless. They're using ultrasonography, using sound waves. So for ladies with breast lumps, and for ladies who are younger than 40 years old, we generally like to have in ultrasound together with a mammogram if there are breast lumps, and if there are no breast lumps, then we tend to still prefer to keep the screening to ladies who are above 40 years old. But yes, breast cancer is on the rise, and someone was mentioning that breast cancer has a profile of it getting younger and younger, and I'll share a little bit about the risk factors later and how we can reduce it. So I'm going to dive straight into this thing about chemotherapy. So, you know, in this day and age of the internet, I don't have to tell you what chemotherapy is. But a very simple sentence is chemotherapy is any treatment that can result in a very quick cell death, usually of the malignant cells. And patients would think of it as, oh, hair loss, nausea, vomiting, low immune system as the side effects of chemotherapy. Well, malignant cells, cancer cells, breast cancer cells, lung cancer cells, they grow very fast. So they are very unstable. Our normal cells don't grow so fast. And in fact, they go through this natural process called apoptosis, which is that when it's time for them to retire, they will retire and they do not continue to collect old age related changes and old age related mistakes. Therefore, a normal cell, whether we affect it with chemotherapy or not, will die on its own when its time is up, unlike a cancer cell, which cannot die on its own, cannot induce apoptosis, which will therefore result in gathering more and more mistakes and therefore becoming malignant and spreading. So yes, when we give chemotherapy, we are targeting the fast-growing cells. Therefore, it can lead to hair loss, nausea and vomiting, because little do people know that our gut lining, our cells in the gut, the cells that line our gut actually is sloughed off every day. That's how we can poo. And we produce saliva all the time. This will carry cells that are sloughed off all the time. So chemotherapy is associated with hair loss, sometimes a bit of forgetfulness, chemo brain, hot flashes, contraception, infertility, so on and so forth. And the one thing is that most people do not, do not want to go for breast cancer screening and a detection, mainly because they fear that the moment they get breast cancer, it will be chemotherapy that follows. But if chemotherapy was associated with no side effects, then ladies would not want to be so worried and they would come forward for examination and diagnosis. It is the toxicities that chemotherapy gives that turns people away. So I wanted to just share with you what's important about chemotherapy. Chemotherapy must do what chemotherapy does. There are a small percentage of patients who do not get much side effects from chemotherapy apart from hair loss. They seem to be well, not so much tiredness, no sore mouth, not much nausea and vomiting. They still carry on with their normal daily activities. Some of them even continue to work. They never have fever, rarely come to hospital. Does it mean that the chemotherapy is not working? Conversely, if we have a patient who gets all the toxicities from the chemotherapy, severe nausea and vomiting, low blood counts, severe hair loss, even the eyebrows are lost, do they do better from the chemotherapy? Well, we do know that constitutionally, there are some patients who are very good at clearing chemotherapy. That's how they are blessed. And then there are some ladies who are unable to clear the chemotherapy. So this is what we call pharmacogenetics. It all really depends on our genes. However, the good thing is that for patients with the side effects, it's actually a good predictor to the response from the chemotherapy for breast cancer. I end that there with a period because it does not mean that if a patient does not have any side effects, the chemotherapy isn't working. What is important is that we mustn't take too much supplements that can reduce short-term toxicities, but affect the long-term side effects and the complications, long-term cure rate from the chemotherapy. Meaning that when we take antioxidants, anti-inflammatory, sometimes a high dose of vitamin C, a high dose of fish oil, all this serves to reduce the side effects of a patient who would otherwise be having the side effects. So genetically, they were prone to having the side effect. They take the supplement and therefore they don't have the side effect. That would not be good because studies have shown that while supplements can reduce the toxicity of the chemotherapy, in the large studies, it actually shows that it may decrease the effectiveness of the chemotherapy, resulting in increasing resistance within the cancer cells. And I have to put a caveat here because we're talking about medications and supplementation, many doses of different types of supplements in order to reduce the side effects of chemotherapy. So a typical patient that we see in clinic will ask, and they will take out approximately 10 bottles of supplement and say, can I take all this? can I take all this? Now, if we take one and not the whole lot, that might be okay. If we take two, that might still be okay. But if we take all 10, then clearly, no matter what inflammation that the chemotherapy can cause, to kill the cancer cells would be reduced. But I just take this thing out, the coenzyme Q10. There are some patients who have very severe side effects from the chemotherapy to the point whereby they cannot see themselves continuing with the chemo. They can barely get out of bed. They've got very severe mucositis. They've got very severe side effects, nausea and vomiting, unable to eat, losing weight. Then occasionally coenzyme Q10 can be permitted on a case-on-case basis in order to help them with their appetite and their well-being so that they can continue with the chemotherapy and complete its course. So when the supplementation is taken without the doctor's awareness, then that was where it can potentially be dangerous. So when we talk about reducing toxicities, if patients have side effects, just let it be, it will pass. But if the side effects are very severe, do talk to the doctors about it. There are some that can reduce the side effects of the chemotherapy, but mainly to know that if we take it in very high dose, it can sometimes result in the effectiveness, reducing the effectiveness of the chemotherapy. So this is one very large study that was recently published to look at dietary supplements used during chemotherapy and survival outcomes of patients with breast cancer enrolled in a very large clinical study. So this was a retrospective study showing and concluding that sometimes when we take high doses of supplements, one of them being fish oil, it can be associated with a slightly lower chance of cure, purely because fish oil, well, some patients take 2, some patients take 5, some patients even take 6 capsules. Some patients take on top of that additional omega in order to reduce inflammation. So this needs to be aware of. Now, then there's the reality is that a lot of patients think that when we give chemotherapy, we leave the patients be. When we give the chemotherapy, we just give it and then we don't give any supportive care. Part of the reason why many patients are not getting any more side effects from treatment is because 50% of the time that we spend giving the chemotherapy, the other 50% of the time we giving supportive therapy. The supportive therapy in the last 10 to 20 years has improved tremendously. All these supportive therapies are done in clinical studies to show that they do not affect the effectiveness of the chemotherapy. In fact, they even help us to give higher doses of chemotherapy in a dose-dense fashion. So if a patient was getting 3 weekly chemotherapy, we give it shorter in a shorter period of time, being able to maintain the intensity of the chemotherapy while not giving the patients additional side effects by giving supportive therapy. So that's why some patients do not have side effects from chemotherapy. So I rarely have to answer any questions when my patients ask me, what's all these drugs that I'm getting? They purely only ask the chemotherapy, but the chemotherapy is 2 or 3 medications. And then the supportive therapy is this whole bag of pharmacy that we give to our patients in order to reduce the side effects, which have been proven to improve the quality of life and to improve the quality of the chemotherapy rather than to reduce it. So anything that your physician can give, your medical oncologist can give you, can help, but don't take supplements outside that. What we do know is excessive nutrition and reduced chemotoxicity. So there are patients who say, can I eat a lot during chemotherapy? I must maintain my weight. So my family is asking me to eat 6 times a day, and each time high calorie food, high fat, high carbohydrate. How does that affect the chemotherapy? Well, generally speaking, for breast cancer per se, majority of our patients actually have an average of weight gain of 1 kilo per cycle of chemotherapy. So if I gave 8 cycles of chemotherapy, that would be an 8 kilo weight gain over a 4 months period to 6 months period. There is no lady whom I know who will be happy with an 8 kilo weight gain over a period of 6 months. They become very unwell. They've got back pain, shoulder ache, because generally this weight gain is not from muscle, but from fat. So many of our patients are insulin sensitive. So when we give enough sugar, it will be converted to fat almost immediately. And the obesity itself causes an inflammation, which would then affect the risk of cancer recurrence. So it's important to maintain and control the weight, control what we eat, What we need to eat, we eat. What we do not need to eat can be forgone. So actually, during the chemotherapy, we must not be afraid of a poorer appetite, because the poorer appetite immediately after the chemotherapy can be associated with just a little bit of weight control, and the patients tend to maintain their weight. So we measure the weight of our patients every time they come for treatment, and the aim is for ladies who are obese to actually lose a little bit of weight. In fact, 10%, 5 to 10% would be good, reaching their normal BMI. And in Singapore, the normal BMI means below 23. In Western countries where ladies are bigger, it tends to be below 25. So by normalizing the BMI, we can improve the chance of cure. Balance of nutrition. This balance of nutrition needs to continue. So someone said this, asked this question just now about what is the single one thing that we can do to reduce the side effects, to reduce the risk of breast cancer? Well, it would be to control the body mass index. I can hear a lot of people telling me now, but the weight and the height is a very simple and a very naive kind of calculation. You know, what if I'm full of muscles? I'm an ultra runner. I'm a bodybuilder. I have very lean muscles, and but I'm heavy. What does that matter? No, it doesn't. It doesn't matter. If a person is very heavy with a lot of muscle mass and with very little body fat, then that's great. But generally, our ladies do not fall into that category of bodybuilders. They generally have a normal body mass. In fact, many of them have a normal body fat, and most of them have a higher body fat. So that's when we use the body mass index as a rough and simple gauge to look at how well a patient is doing. So if there's a single thing that we can do, is to try and reduce the body mass index to normality, which is 23 in Asia. So that affects the survival. A normal BMI is associated with a higher chance of survival, and an increase in physical activity is associated with an increased chance of breast cancer survival. So coming down to the main facts here, who can forego chemotherapy in a curative intent, determining the real benefit of chemotherapy? So stage is the best determinant of prognosis. If I am diagnosed at an early stage, my chance of cure is high, period. If we take home nothing else from this particular webinar, it is that stage is the best determinant. So do not be afraid of coming forward to get diagnosed early, because no matter how aggressive a breast cancer is, if it's early stage, the chance of cure is still the highest. Therefore, cancer screening is still the best at early detection. Education, mammograms, ultrasound is an adjunct, self-breast examination and genetic testing for high-risk individuals. How do we classify breast cancer? Actually, tumors with similar morphology, same size, number of lymph nodes that are affected, have different outcomes and response to chemotherapy and to therapy. So we generally stratify them into the low and the high risk. Looking on the green side, we call them the Luminal A, low-grade type of cancer. And these are the cancers which are picked up by mammogram on a year-to-year basis. They change from microcalcification that are benign looking to microcalcification that are malignant looking as the lady ages. But because it's slow growing, we can afford to take time to watch them on mammogram changes year on year on year. But when we then reach on the right side of this graph, it's called Luminal B, or HER2 or basal type, which is triple negative. They are aggressive. They can tend to grow very quickly between one mammogram interval and another mammogram interval and appear as lumps. They don't generally, sometimes they don't produce the same microcalcification changes. Therefore, they can only be picked up by ultrasound. Some of them can only be picked up by physical examination and MRI scan, and mammogram can miss it, in inverted commas. So between the luminal type A, which is slow growing, and the luminal type B, HER2 and basal type, there are different ways of detecting. Luminal A tends to occur in older ladies, and luminal B tends to occur in younger ladies, which is why ultrasound is important for ladies who are younger. Mammograms are important, usually more beneficial, more accurate in the older ladies. So let's look at this tool, decision-making in breast cancer. So if we have a 56-year-old with 2 grandchildren, no family history of breast cancer, history of diabetes, she has a 2.5 centimeter grade 2 1 lymph node positive. Traditionally, because the lymph node is positive, we would recommend chemotherapy followed by letrozole because or anti-cancer hormones, because there is a risk reduction of 10% with chemotherapy and 20% with letrozole. On the other hand, we have a 39-year-old lady with 1 child, no family history, 1.5 centimeter, grade 3, no lymph nodes, early stage, traditional. Again, we would recommend chemotherapy followed by tamoxifen, risk reduction of about 6 to 8% with tamoxifen. So you look at this, there's no difference. 56-year-old with 1 lymph node positive, 39-year-old with no lymph nodes, both you would recommend chemotherapy until we look at this thing called the luminal A and B. Luminal A and B are both estrogen receptor positive, but one is a low grade, as I mentioned, detected usually by mammograms, associated with obesity, older age, and hormone replacement therapy. There was a question about that just now from the audience. And treatment with anti-cancer hormones are adequate if found in the early stages, meaning chemotherapy has little to no benefit in patients, especially if they're postmenopausal. In luminal B, again, they're ER positive, but they are high grade with a higher chance of recurrence. Again, it's mammogram detected or can be a lump that is felt associated with younger age, family history, and treatment with chemotherapy, even in early stages, will benefit, which is different from the luminal A. So this is where we need to be clear whether it is a luminal A or a luminal B. If they both look the same, except for the grade, is there another way that we can tell? So there are several of this genetic, not genetic testing as in the Angelina Jolie genes, but genomic testing in the tumor to find out if these tumors are low grade or high grade. There are 3 that is available in Singapore right now. We send it overseas to the companies that own this patented technology. There is the Oncotype DX, there is the MemmaPrint, and then there's the EndoPredict. So if your doctor has told you, oh, well, this one is a hormone-sensitive breast cancer, we want to know if chemotherapy would benefit, they might send it for one of these tests, which would then show up if it's a high risk of recurrence or a low risk of recurrence. If it's a high risk of recurrence, called a high-risk cancer, then it's the luminal B. If it's a low-risk cancer, then it's considered as a luminal A. Luminal A, low risk, no chemotherapy, not because chemotherapy is bad, but because chemotherapy is associated with a small and potentially insignificant benefit. If a patient still wants to have chemotherapy, it's not wrong, but it's just not worthwhile because the side effects may outweigh the benefits. But in a patient with a high risk group, chemotherapy is beneficial, not because they will definitely recur, but by giving chemotherapy, we can increase the chances of cure. So there is a difference because a patient will hear high risk and they will panic and they say, oh my God, I'm going to die because there's a high risk of recurrence. No, by definition, it just means that if it was a high risk, chemotherapy would benefit, and if it was a low risk, chemotherapy would not benefit. This is the other test called the MemmaPrint, where discordant cases, discordant means it looks relatively benign or it looks relatively high risk, but when we send it off for MemmaPrint, it comes back as low risk for the high risk and high risk for the low risk. So it's like, oh, it turned out that while my tumor is stage 2 because I've got 2 lymph nodes that are positive, I didn't need to have chemo, or chemotherapy was not associated with a significant benefit. Whereas I can have a small tumor, which looks clinically low grade, but when I sent it off for the MemmaPrint, it came back as high risk, meaning I might even afford a 20% advantage from taking the chemotherapy. So by sending off for one of these tests, Oncotype DX, MemmaPrint, and EndoPredict, we can predict whether a tumor that is estrogen receptor positive is going to be high risk or low risk, thereby helping us and our patients to decide whether chemotherapy is worth their while. Chemotherapy is not to be feared, but at least be beneficial. If it's not going to benefit, then any treatment is considered as unnecessary. If it benefits, then any treatment, no matter how toxic, it is significantly helpful, and therefore we'll still recommend it. So whom would I choose for chemotherapy? Low estrogen receptor positive, negative PR, HER2 depending on the ER positivity. And of course, nowadays, there are many choices of chemotherapy, but for main discussion of this particular talk, it is usually the usual doxorubicin, cyclophosphamide, and paclitaxel. So there are two of this, which I will not dwell into, but these two, the HER2 positive and the triple negative breast cancer, are all high grade. All patients with a HER2 overexpressed breast cancer and triple negative breast cancer, short of those that are less than 0.6 centimeter, early stage 1 or the in situ cancers, they would all benefit from chemotherapy. Generally, they are associated with a younger age. Generally, they are associated with a high inflammatory reaction in the body, associated with obesity, associated with chronic inflammation. Both of this would benefit from chemotherapy. In fact, if the tumor was larger, they will be candidates for neoadjuvant chemotherapy. We would give the chemotherapy before the surgery to shrink the cancer, not just so that we can do conservative breast surgery, but also that we will know the true tumor biology. Is it responding to my treatment? If it is, then it's associated with a much higher chance of cure. So for the high-grade tumors, we give the chemotherapy before the surgery in patients who are considered as inoperable or where the tumor is high risk, so that we can see if they respond very well to the chemotherapy as a prognostic index for future cure rates. So this is just a very busy slide on the different types of chemotherapy. So far, fortunately, if any patients were to come and see me about 3 to 5 years ago, we used to have a complex table of what different chemotherapies to have. But nowadays, it is down to doxorubicin, cyclophosphamide, paclitaxel, those stands, and the use of targeted therapy in the HER2 overexpressed breast cancer and potentially immunotherapy in the triple negative breast cancer. But if we wanted to know the details about chemotherapy for patients, that would be in the next talk. We're talking about who does not need chemotherapy here. Now, what about for patients with incurable cancer? If they are for palliative intent, do we always need to give chemotherapy? Also not absolutely. In fact, in patients who have stage 4 breast cancer, we need to find an alternative to delay chemotherapy as much as possible. Again, advanced breast cancer is a very heterogeneous disease. They are still divided into the luminal A, luminal B. The extent and start of disease, as well as the prior treatment, will help us to decide. If they are chemo and treatment naive, never had chemotherapy before, and they presented with a slow growing tumor, we still see patients like that where they come in and they have had breast lumps for probably more than 5 to 6 years and just told no one until recently. And then we do a scan and then we find that it's spread to the bones, but only the bones. And then on history taking, they might have had this problem for more than 5 years. And clearly they're still well enough to come and see us with very little volume of disease. These are patients who do not need to have chemotherapy at the beginning. We treat them with anti-cancer hormones. This is a very busy graph. We treat them with anti-cancer hormones. And nowadays we add targeted therapy called CDK inhibitors. But I just want to share, because this is a slide where probably most patients have not come across, in that while there is a lot of development in the chemotherapy over the last 30 years, going from anthracyclines, taxanes, oral chemotherapy, targeted chemotherapy, at the same time, since 1896 up until now, the last 100 years, we've learned a lot about the anti-cancer treatment of patients with low-grade, slow-growing, ER-positive stage 4 breast cancer. Going all the way back to 1896, in fact, at that point in time, there was no chemotherapy, there were no medications, tamoxifen hadn't been discovered yet. The treatment of choice for advanced breast cancer was a surgical oophorectomy, meaning we went in and removed the ovaries for patients who had breast cancer because the hormones in the ovary would drive the breast cancer. So just now in the audience, someone asked this question: how important is it for a patient with early cancer to be treated with ovarian suppression together with tamoxifen? It really depends on the age of the patient, and the size of the tumor, how high the risks are. If the risks are high enough, then ovarian suppression, ovarian ablation would be necessary. So chemotherapy versus endocrine therapy in patients with slow-growing breast cancer in the stage 4 setting, it does not mean that chemotherapy is necessarily faster. In fact, anti-cancer hormones can work very fast in an exquisitely sensitive breast cancer. So it all depends on the biology of the cancer. If it's a slow-growing cancer, a luminal A, sometimes because of the lead time to the time that they were diagnosed is unfortunately advanced, we can actually give patients no chemotherapy for up to 5 or 6 years using anti-cancer hormones, after anti-cancer hormones, after anti-cancer hormones, together with targeted therapy, and they can continue to work and live a normal life. What about triple negative breast cancer? Does all triple negative breast cancer patients require chemotherapy? There is up to 15 to 20% of patients with triple negative breast cancer who have the Angelina Jolie gene, now known as, of course, the Angelina Jolie gene, because she was the one that popularized it, but it is otherwise known as the BRCA or breast cancer gene mutation. Since Angelina Jolie and her popularization of this particular gene, there's been a lot of discovery on the different mutations. There are BRCA1, BRCA2, and then there are the BRCA-like breast cancers, which express this thing called the homologous recombinant deficiency. A bit complex, but basically it means these patients can benefit not just from chemotherapy, but also a targeted therapy called the PARP inhibitors. So again, not all patients with fast-growing triple negative breast cancer will require chemotherapy. A portion of them, if they are BRCA mutated, can just be simply treated with an oral medication. So there are many, many targeted therapies that we can use in patients with ER positive and triple negative breast cancer patient. But I just want to share a case study with you before I go on to the final segment. This is a 45-year-old lady with estrogen receptor positive stage 4 breast cancer. Now we're in 2020 and she was diagnosed in 2015. She was diagnosed with cancer that spread to the liver. So when we say spread and we say liver, we often, more often than not, think of chemotherapy. But she had been through multiple chemotherapy agents before coming to see me. And the cancer was very slowly progressing, but it was surely progressing, but very slowly so. And she clearly been surviving for 5 years now. She had gone beyond the norm of a 5-year survival of a patient with cancer that spread to the liver. Eventually, I persuaded her to go undergo ovarian suppression. And she commenced on Zoladex, Faslodex, and a CDK inhibitor, and she's responding well to treatment. We would otherwise not imagine that a premenopausal lady who's been diagnosed 5 years ago and had multiple chemotherapies respond to treatment. So sometimes a hormone-sensitive breast cancer is best treated with an anti-cancer hormone rather than chemotherapy. So again, back to this thing, keep calm and live. Cancer prevention recommendation by the World Cancer Research Group is number 1, keep weight low within healthy range, be physically active for at least 30 minutes every day. Actually, the more the merrier. It all depends on the tolerance level of a lady. If you told an athlete to go out and be physically active for 30 minutes, she will say, but I'm physically active for 120. Is it too much? Not at all for an athlete, but it really depends on the pre-morbid activity of that person. Avoid high-calorie fruit and sugary drinks, eat more grains, vegetables, fruits, and beans, and limit, not eliminate, but limit the intake of red meat of less than 500 grams a week and avoid processed meat. So what is 500 grams a week? My palm, the size of my palm is 100 grams. So 5 portions of this the whole week. I dare say that if I spoke to any Asian ladies, they'll say, oh, that's too much. I don't eat so much red meat. So it is not a problem in Asia. It is more of a problem in the other countries. But if you are a lover of red meat, then just sit tight. I'm going to talk a little bit more about that. Eat less salt and avoid moldy grains and cereal and aim to meet nutritional needs through diet alone. I'm just going to share a few slides about cancer causation and what to do. So we know that cancer is caused by formation of free radicals, smoking, pollution, infection, inflammation. But what we don't know is this thing called the estrogen metabolism, meaning there are many different types of estrogen in our body. We produce estrogen even when we are postmenopausal from our adrenal glands. There are then the phytoestrogen from soya and from food, and then there are the xenoestrogen, which comes from plastic and cosmetics, which WHO and NIH is beginning to recognize as a potential carcinogen. So when there is enough xenoestrogens in the body that can lead to poor and malignant cellular proliferation and differentiation, when there is a normal estrogen and endogenous estrogen and is controlled in the premenopausal ladies, and we have phytoestrogens, that leads to a normal mammary gland development. Without the normal estrogen in our body, we will never develop breasts, we will not have puberty, we cannot produce milk for our babies. So essentially, the estrogen that is produced by our body, these are good estrogen, but then they are the bad estrogens. So DNA damage, mutation, and cellular transformation that is associated with estrogen metabolism is that the scientists have found that there are certain estrogens there are certain artificial estrogens called xenoestrogens that actually causes DNA damage and results in breast cancer. Just to name a few, this is things like pharmaceuticals, cosmetics, petroleum distillates, baby bottles, BPA, detergents, pesticides, shampoos, and otherwise known as parabens. So years ago, there used to be a lot of denial about the fact that parabens and organophosphates, pesticides can cause this. But as early as 1970s, DDT, which is a very common pesticide used in those days, was immediately found to cause breast cancer, and it was then banned and prohibited from use. But clearly, there are many countries where it is not as advanced. There are still people who use DDT for pesticides. And of course, the very famous BPA. So now we have all these BPA-free bottles and paraben-free cosmetics. So if I really wanted to eliminate or reduce my risk of being exposed to this, that is important to actually clear away from parabens and pesticides. What about hormone replacement therapy and breast cancer? This was a paper that was published recently in that they have finally concluded that hormone replacement therapy can be associated with a slightly increased risk of breast cancer. So what does it mean? Does it mean that all ladies should not be getting hormone replacement therapy? The answer is no. Some ladies do benefit from having hormone replacement therapy if they are having an extreme bone loss, or they are having very severe depressive and emotional changes due to the change of years. They can have a short stint of hormone replacement therapy and still be safe, but they should not be considering hormone replacement therapy continuously forever without knowing the risk that they can develop breast cancer. So they must be checked out, they must be regularly examined, they must get regular mammograms. Finally, a few slides about diet. Soya food intake and breast cancer survival, soya food intake and breast cancer risk. In most meta-analysis and studies, there is no increase in the risk of eating soya products, but in nutritional form, meaning that if I took soya supplements to have beautiful skin or to enhance the size of my breast, then we don't really know what type of soya they use, and we don't really know how high the dose is. It is rarely physiological. But if I ate a lot of tofu, and I like to eat tofu, I like to eat green beans, I like to eat this versus meat, then that would help me to reduce the risk of my breast cancer. So meta-analysis, which is a collection of a lot of clinical studies, have shown that soya intake does not increase the risk of breast cancer. What about a diet high in red meat, processed food, dairy? Is it associated with increased risk of cancer? It is possible. There are some studies that show that a diet high in animal fat, specifically animal fat, so not lean meat, and specifically barbecued animal fat and barbecued animal meat, and the processed meat is associated with the risk of cancer. It's not just for breast cancer, colon cancer, children's leukemia. Many different cancers are associated with a diet that's high in meat and processed meat. Whereas consumption of vegetables, fruits, that's mainly borderline. Some protective, some show no benefits at all. The only thing is that if we say if I turn vegan, would that help me? Answer is no, because a higher fish consumption was associated with a decreased risk of breast cancer. So with that, I am gonna thank you for your attention, and I think we can have 5 to 10 minutes for any Q&A. Dr. Wee, do you have any questions that you've come across here that you might want to bring up for discussion? I think one of the questions that keeps coming up is this thing about microcalcification. You know, maybe you can just share with us in a short couple of minutes what's this thing called the BIRATS, because I keep reading it on the mammograms.
Okay, essentially the BIRAT system is a reporting, is a categorization of the likelihood of cancer based on the imaging characteristics, whether there are calcifications, whether there are lumps, whether there are densities. The radiologist will come down with not all, but in general, it's a very accepted kind of system where it comes up with what you call the BIRATS system. BIRATS is a long word, it's an acronym for breast imaging, reporting, and scoring system or something like that. Now, it's categorized BIRATS 1 to 5. 1 is normal, 2 is benign, which is no cancer. Category 3, BIRATS 3 is probably benign. Category 4, BIRATS category 4 says suspicious. BIRATS category 5 is highly suspicious of cancer. So the very good ones to have would be if a report says BIRATS 1 or 2. You can always rest easy. BIRATS 3 is the one that has the big range of likelihood of cancer. It can range from something in the region between, on average, about 3% to something like 60, 70%. So BIRATS 3, BIRATS 4 are things that we start to get anxious about. Of course, with BIRATS 5, it's out of the question. So oftentimes, BIRATS 3 is one of those that says probably benign, which means all the features are likely to predict a non-cancerous situation. And those are things that require monitoring. BIRATS 4 is one of those where I think most clinicians, most doctors will say, let's be sure that this is not a cancer. So some form of treatment will be needed by way of a biopsy as a minimum in categories of BIRATS 4. When it comes to BIRATS 3, probably benign, which is not likely to be cancer. The process of monitoring is advised. Again, there's always be a discussion as whether we should consider even doing a biopsy at that stage rather than waiting, and it's a discussion the doctor will carry out with the patient. And back to the question of microcalcifications. Microcalcifications, as I showed in the slide earlier in my presentation on the mammograms, are little tiny dots, white spots or deposits of calcium that can be seen on the mammogram. By and large, they are benign in nature. There are many harmless causes for calcifications to occur in the breast. Most common cause that women don't like to hear is aging. But sometimes early cancer presents as microcalcifications. How do doctors determine? It is a very visual kind of assessment. We look at the mammograms, we look at the dots, the size of the dots, the number of the dots, the evenness of the dots, as well as the overall pattern will give the viewing doctor an indication as the likelihood of cancer. And on that, and based on that, the advice of whether something should be done will be discussed with the patient. Okay.
Okay, we're having a lot of questions about this stage 0 breast cancer, so in situ cancer.
Yes.
You know, there's some controversies about whether we should even be called it cancer. You know, what do you think, Dr. Wee?
Okay. Essentially, it's how the terminology has been derived and the classification has come about. Stage 1 cancer, of course, is how cancer, I believe, was first defined. In stage 1, from stage 1 onwards, 1, 2, 3, 4 are all what we call forms of invasive cancer. That means cancers of the breast that has escaped the confines and has the potential of spread. Then with imaging, we start to discover earlier and early forms of cancer, and therefore it falls within the category of what we call stage 0 breast cancer. Now, stage 0 breast cancer refers to cancers developing within the duct of the breast, and it is caught at the phase before the cancer has started to go and invade the basement lining, the ductal lining, to start spreading. So we're actually catching a cancer in a very early form. It is still called a cancer. It's still called cancer of a zero stage, in the sense that it is still a cancer. You leave it long enough, we believe it will evolve into stage 1, stage 2, stage 3. The challenge here always is when you find a stage 0 breast cancer, as I mentioned, if the cancer doesn't escape, it doesn't kill the patient, then some people by definition will say then it's not cancer because it's not deadly. So that's how I think the categorization makes it a bit confusing. Stage 0 cancer is still cancer. Some patients mistakenly call it pre-cancer, but it's actually not pre-cancer, it is cancer. And therefore it has the potential to kill. But it's just that we have the ability in this form of cancer to catch it so early before it even acquires the ability to spread. And that's why the appeal we have is catch the cancer early. If you catch it at stage 0, your life actually in general is not threatened. And that I think is the earliest chance we can try to help the patient.
You know, I have a lot of questions also about patients, you know, with genetic mutation for risk reduction mastectomy. But a lot of patients call it preventative, you know, versus risk reduction. It used to be called preventative breast surgery, prophylactic mastectomy, but now it's called risk reduction mastectomy. Can you help us to explain that to our audience?
I think the terminology has changed. I think my understanding is, again, it's the use of English words. The original intent of a prophylactic, which by direct translation means preventative in a lay language, connotes a very powerful kind of a message. When you say you're doing something that's preventive, most people adopt the thinking that, that's the way I feel it. Most people adopt the thinking that it is absolute. If you do this, the prevention is a very powerful message. But risk reduction in reality is what we are trying to achieve. So actually they are used synonymously, but I think we move towards calling it risk reduction to try to accept that even if you adopt this approach, it is not absolute that you're 100% protected from breast cancer. That's my understanding of the way it has come about. So it can be used interchangeably, but the main message at the end of the day is even with a preventive mastectomy, or what you call a prophylactic mastectomy, technically, we will say that we have removed all the breast cells from that breast, such that there are no breast cells left behind that can undergo a cancer change. But we call it risk reduction because it is technically impossible to remove every single cell. Cells are microscopic. You leave the skin of the breast to do the reconstruction. So technically, there can be some small cells still left. Also, in order to enhance the appearance, we tend to also leave the nipple. And the nipple also has some breast cells at the back of the nipple as well. So you cannot say that with a prophylactic mastectomy or preventive mastectomy, we have removed all the risks for breast cancer for the reasons I just mentioned. And therefore, we now call it just a risk reduction. But it doesn't make it any more dangerous or any less dangerous, but it's just the way I think the terminology has come along.
Yeah. There's still quite a number of questions that's coming through. I'm just going to, for the interest of time, read some of this. You know, there are many people who want to know what are my risks of breast cancer at any timeline. I think my answer to the audience here is that our risks change. When I'm 20, I'm a very athletic person, I eat very healthily, and I exercise, and I'm a high school runner, then clearly my risk, if I continue doing that, my risk when I'm 50 will be low. But at 30 years old, I decided I'm going to let it go. I don't want to run anymore. I don't want to do any more activity. I just like to eat ice cream every day and don't focus on any physical activity. And I put on something like 30 kilos, have a BMI of 35. Then basically, I'm increasing my own risk of breast cancer over the years. So our risk factors changes. Even for patients with genetic mutation carriers, we can actually reduce our risk by living differently. So if I used to be obese when I was a teenager and I decided to lose a whole lot of weight, go down to normal BMI, become very active, I can actually reduce my risk of breast cancer by 40%. So studies have shown that by simply changing lifestyle, nutrition, activity, we can reduce our risk by up to 40%. And that's more powerful than any other preventative measures. And this thing about mammograms, you know, mammograms are like taking a photograph of a person at that point in time. Imagine if you were to wake up and your hair is up here somewhere where you haven't brushed it yet, and somebody decides to take a photograph of that, and then you rectify it, and a year down the road you can't see it anymore. Is the original one important? No, it's not. But when there are changes that are progressive, if every single day Dr. C does not brush her hair and it remains high and I don't cut my hair and something's not right, then clearly I'm mentally unsound. But it takes time to monitor that. That's the same thing with the mammogram. When we follow mammograms, we follow up for changes that are not normal. They look quite normal at the beginning, then they begin to look suspicious, and they finally look so suspicious that we cannot ignore it anymore. So these takes time to actually change. So there are still many questions that are coming in, which are actually pertaining to some of the side effects of the treatment. I'm afraid that that's not possible for us to answer on this forum. But I do encourage you to read a little bit more and talk to your doctor about your problems. With that, Dr. Wee, do you have anything else that you'd like to share after looking at the questions?
There's just a question that I want to just pick up on a couple of them, just to rather than just spend the time typing and share with everybody. One question is mastectomy better at preventing relapse than a lumpectomy? Now that's a question with the assumption that, of course, the recommendation given would be that the patient has the option of both saving the breast versus a mastectomy, which is complete removal of the breast. Now, a large part of this discussion comes down to understanding the features of the cancer and the recommendation of the surgeon to follow. If you just put it at face value, is removal of the breast better at preventing a relapse compared to when you just remove only a portion of the breast? The straightforward answer simply is yes. I mean, at the end of the day, it is almost logical. If you have a breast that has cancer before, if you remove the breast and you minimize the amount of breast tissue left behind, the remaining breast tissue, left so little, the risk is actually a lot lower than if you have left a large part of the breast behind. Because the whole concept of lumpectomy is to leave the breast with cancer after treatment, after surgery, to look almost like the other side. So you're actually leaving a fair amount of breast tissue behind. Therefore, the risk is always automatically there because breast cells are still there. So the understanding has got to do with, is it safe enough to offer lumpectomy instead of mastectomy? If your surgeon deems it's safe enough, then the discussion is, what is the likelihood if you do so? And likely risk depends on the features of the tumor. So this is actually no different. The analogy I share with my patient is like you have a bad rotten tooth. Is there a carie in your tooth? The dentist says, well, you know, I can fill the tooth or I can pull the tooth out. And you ask the dentist, what is the likelihood of me getting a dental carie again in this tooth? Almost, of course, if the tooth is there, it's there. But if you remove the tooth, it becomes zero. So again, it's at the end of the day, a discussion that's actually very important to carry out with your surgeon in relation to his view and the features of your tumor. And so I don't think there's a simple answer on that. The other one I would just want to pick up on was on the question of whether, somewhere I saw it somewhere, about cancer of the cervix in relation to cancer of the breast. Is there associated risks? I don't see that as an associated risk in the sense that they are actually quite separate. Anything else? If you reach 5 years with a good re-evaluation results, does it mean you are cancer-free?
Well, I think ladies are living longer and longer.
Yes.
So we even have patients with stage 4 cancer that live more than 5 years. We used to discharge patients at 5 years. Now we try to discharge patients at 10 years, but our patients prefer to come back and see us for 20 years. So just mainly more to see if there were things that are changing. In fact, Dr. Wee tells me that some patients come and see me and they're very stressed out because I tend to look at patients on a year-on-year basis, and I tend to frown when they begin to put on weight as we all age together. You know, every 5 years, if I see someone putting on 10 kilos, I do say something. So because our risk changed, during the chemotherapy, everybody's very careful about what they're eating. Once the chemotherapy finished, they almost always let go. The stress comes back, the exercise drops, the nutrition drops, everything just let go. So I really do encourage that the urgency at which individuals before and after breast cancer to deal with their lifestyle changes needs to be lifelong. That's why we call it lifelong changes, lifestyle changes. It's not just about during the chemotherapy. It doesn't, you know, We drive cars. People who drive cars, we regularly send our cars for servicing. Why can't we service our body the same way? We need to pay a little bit more attention on what we put into our mouth and what we do every single day. Fortunately, eat less, move more is always a good thing. So this risk continues beyond 5 years. So thank you so much, everybody. I do encourage and please help us with the feedback. I am really sorry that we cannot answer all the questions. We've answered approximately 70 questions with about 3 or 4 questions still open. But I encourage you to email us if you have any burning questions you need to ask. And if you have any symptoms that you find yourself that's similar to what Dr. Wee has said, please find a family doctor or a physician who can help you diagnose breast cancer early. This is the whole point about October being Breast Cancer Awareness Month. You need to just be aware. We're not here to scare you. We're not here to tell you what you did right or wrong. We just need you to be aware that breast cancer can be prevented, but it takes a few years to do that prevention. But it's most important for early detection because that's associated with the highest chance of cure. And with that, thank you very much for your kind attention. Thank you, Dr. Wee, for spending Saturday afternoon with me. And thank you very much, everybody.
Okay,
Please
thank you,
do our
everybody.
feedback for us.